Alrighty, let's get started. Welcome to Patho again, another week of pathophysiology. I'm going to share my screen and we'll take a look at the Canvas course shell to just see where we are at. If I click under modules and scroll clear down, we're well into section 6. And today what we're going to talk about a little bit is the PowerPoint. You do have access to these PowerPoints, chapter 8, 20, and 21, which are all the respiratory type stuff. We're going to go through chapter 21 for a bit today, more respiratory stuff. For you guys that are keeping up on your Davis modules, which everybody's doing a great job of, you may have noticed, I'm going to go out to FA Davis. There's not a lot left in this class. We're well, oh, that's not going to let me because I'm in student view, but there's not a lot left on those Davis Advantage modules. So that's pretty exciting. I'm going to Anyway, I guess I won't go out to Davis, but if you've noticed, really the hard stuff is the heart stuff. Next week after we'll take our exam, and then we're going to dive into some pretty difficult content, which is that kidney stuff. We're going to talk about kidney stuff. And then it's pretty much downhill from there. So especially if you're reading the content in the book, we're really at kind of a tipping point where things will start to repeat themselves, and we're making crazy progress. It's super exciting. So that's where we are in the class. Does anybody have any questions at all? This chapter 21 PowerPoint is what we're going to dig through today. What I'm actually going to do, just to change things up a little bit, is start at the end of the PowerPoint. Partly because the beginning is super boring, and partly because the disease process at the very end, the very last disease process that this PowerPoint is talking about is adult respiratory distress syndrome. And I want to make sure, there's only 2 slides on it in this PowerPoint, which I think is silly, but the book authors didn't know that we were going to have a pandemic this year. And so tons of people are dying from essentially ARDS. So we're going to talk about it a little bit in depth today. Before I dig into the PowerPoint, I want to show you a fun way to study. The way that I like to dig into really complex pathophysiology, it's kind of my secret pleasure in a sense, is I like to go to Wikipedia. And one of the reasons I like doing that is all of my nursing instructors would be rolling over in their graves. They knew I was hitting Wikipedia. I love Wikipedia so much, I donate money every year, tons of money. They hit me up once a year, and I give them $3. So I support Wikipedia, big fan of it. Healthcare really frowns on Wikipedia because there's this fear that it's not peer reviewed, and there is definitely some truth to that. So when you go to Wikipedia, just have it in the back of your mind that some 13-year-old kid somewhere in the world could have edited that Wikipedia page. If somebody does put something ridiculous in a Wikipedia page, it usually only stays up for about 24 hours. But just keep in mind, you can't cite Wikipedia. But when there's a new disease process that I want to thoroughly understand, this is where I start. So I'm going to type in ARDS into Wikipedia, the free encyclopedia. And it says there's different things that ARDS could stand for, but the very first choice, acute respiratory distress syndrome. Notice Wikipedia has it correct and your book doesn't. Your book calls it adult respiratory distress syndrome. So right there, we've already learned something. We've learned that the politically correct thing to say now, acute respiratory distress syndrome. And then the very next thing that we notice is there's a super cool chest x-ray right there. Interesting. Now we know what a chest x-ray of a person with severe ARDS looks like. I can't really read chest x-rays. As nurses, that's not something that we're trained to do. If you're in the radiology tech program here at the college, Rad Tech, also they don't read chest x-rays, but they do have to learn how to take chest x-rays. And they get pretty good at identifying it because they do it all day. According to Wikipedia, this chest x-ray demonstrates widespread ground glass appearing opacities in both lungs. So if you look at this chest x-ray, apparently we are looking at ground glass opacities. It does look kind of hazy to me. Good lung tissue should be black on the chest x-ray. And it's not very pitch black on that. So I guess we're calling that ground glass opacities. I've seen one test question on one exam in my entire nursing career where the exam wanted you to know what ground glass on the chest x-ray meant. Ground glass on the chest x-ray means ARDS. ARDS is an important thing to know about because the book makes it sound like this is just an occasional thing that just randomly happens, but it's not. I consider acute respiratory distress syndrome simply part of the dying process. Part of the dying process. So essentially, everyone who dies will eventually have ground glass opacities showing up on their chest x-ray. If we read Wikipedia, it says acute respiratory distress syndrome is a type of respiratory failure characterized by rapid onset of widespread inflammation in the lungs. Widespread inflammation. So when we're looking at this ground glass opacity, what we are really seeing is the same thing that happens when you sprain your ankle. If you're leaving your house later today and you misjudge where the curb is and you trip, twist your foot, sprain your ankle, the inflammatory response kicks in and you start to get swelling and pain and edema. That's essentially what's happening at the cellular level in your lungs when you have ARDS. Lots of things can cause inflammation in your lung. Most commonly, what we see in the hospital is sepsis. Very common. And in fact, it's really considered part of the constellation of sepsis. You can experiment with this later today if you would like. If you'd like to feel what ARDS feels like at a very, very mild level, drink a bunch of alcohol. Drink a bunch of alcohol. As it turns out, alcohol is a very potent pro-inflammatory toxin, and it affects every cell in your body, but specifically your lungs at a cellular level. Alcohol causes inflammation. What's happening is the little white blood cells that are in your lungs, the white blood cells that are hanging out in your alveoli, which is a little tiny air sac, those white blood cells get angry. They're completely pissed off. Angry white blood cells are responsible for the inflammatory response. And so you may have noticed last time you went to a Husker football game and you hit the bars afterwards, as everybody does, and you had a bunch to drink. When you got home, you passed out, slept fine, but when you woke up in the morning, you had a cough and you felt like you were getting a cold. That's essentially, it's not called ARDS, but it's essentially inflammation in your alveoli. And part of the reason we think that your lungs are affected is because you exhale ethanol. That's the same way, or the same reason, that the cops use a breathalyzer to find out if you're driving under the influence. Because when you breathe out, you can't hide the fact that you're exhaling alcohol or ethanol. It's directly inflammatory to the lungs, and it really looks a bit like ARDS. If you work in a trauma center later on in your career, if you're working in a major ER that sees a lot of trauma patients, you'll notice in the second paragraph here in Wikipedia that causes may include sepsis, that's common, pancreatitis, and number 3, trauma. So trauma itself is a cause of ARDS. And the thing I love about Wikipedia is if you hover over any of these, it has a hover to discover feature. What is trauma? Well, trauma is any injury, blah, 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 blah. A common example for someone who is highly intoxicated after a Husker game and decides they can drive home. They take off down South 9th Street, which is a one-way street heading out of downtown Lincoln. 85% of all the DUIs in Lincoln are on South 9th Street because all of the bars head that way. So you're heading down South 9th Street at a high rate of speed and you misjudge where the curb is. You hop the curb and head on into a large tree. Your chest hits the steering wheel. You are now a trauma patient. But you're also a trauma patient who has alcohol on board. Double whammy. Very few, statistically, very few trauma patients don't have alcohol on board. For example, motorcycle crashes. How safe are motorcycles is a common question ER nurses get? Would you drive a motorcycle? They're little death machines. But statistically, if you take out all of the alcohol in the world, motorcycles are an extremely safe mode of transportation. Something like 80% of motorcycle fatalities, there was alcohol involved. Either the motorcycle rider or the person that hit the motorcycle rider. One of the two had been drinking. The other thing that Wikipedia says is a common cause of ARDS, pancreatitis. I'm hovering to discover because I can't quite remember what the pancreas does. Pancreas is sitting there in your belly and it's doing stuff. It helps with digestion. It also helps with blood sugar control. Alcohol is the leading cause of pancreatitis. Pancreatitis is a leading cause of ARDS. Anyway, that's Wikipedia, and that's what they have to say about ARDS. If you scroll down through here, it just tons of information. If you read this Wikipedia page on ARDS, you would be a world-class expert on this one thing. I'm going to stop sharing for a second because sometimes if somebody joins Zoom, I can't see that I need to click the admit. The treatment, according to Wikipedia, it's usually treated with mechanical ventilation in the intensive care unit. Oh, there's something popped up. Gotta hit admit. And because the textbook treatment for acute respiratory distress syndrome is mechanical ventilation, this is why exactly a year ago today, about March of last year, we were freaking out about the COVID and the lack of ventilators. We really thought we were going to run into a worldwide shortage of ventilators. And in some locations, we did. In New York City, we had a shortage of ventilators. In most locales here in Lincoln, we never really ran into that problem, thank goodness. We had enough ventilators to go around. But another really exciting thing happened with the pandemic is we started to realize that we can treat people without putting them on the ventilator away. So that's a new thing that we've kind of discovered just because of this pandemic is not everybody needs the ventilator. Another thing that if you decide to go work in an ICU, ECMO. And what is ECMO? Well, it just has a whole paragraph that explains it, but there's also a hover to discover feature. And so to be an ICU nurse that takes care of ECMO patients, you have to have additional training. After you pass your NCLEX and you become an RN, you get a whole training on ECMO, which is a pretty cool technique for supporting a person in ARDS, acute respiratory distress syndrome. Prognosis of ARDS is poor. And again, this is in your book. Your book talks about this, and we'll go back to the PowerPoint in a second. Mortality rates, about 40%. If you catch the ARDS, you got about a 40% chance of dying. All righty. I'm going to X out of Wikipedia. When we talk about acute respiratory distress syndrome, it is part of the dying process. And what I mean by that is everybody who usually sepsis is the big problem. Somebody gets septic, which technically means they have bacteria floating in their bloodstream. That bacteria is just getting pumped all around their body. The heart is circulating your entire blood volume. And so you got that bacteria floating in your bloodstream. You are septic. And then once your blood pressure starts to drop, we call that septic shock. And then you start having body organ systems shut down. And so in the whole grand scheme of things, the dying process is called, in your book has a whole section on this, MODS, multi-organ dysfunction syndrome. Multi-organ dysfunction syndrome. It's called MODS. And one of the very first organ systems to take a hit often is your lungs. If your lungs take a hit, we call it ARDS. Another body system that's usually your number 1 or 2 to take a hit are your kidneys, which we will talk about, I believe, next week. When your kidneys take a hit, you have a 40% chance of dying. If your lungs are what take a hit, you have a 40% chance of dying. But if you hit both organ systems, so your kidneys take a hit and your lungs take a hit, you now have 60 to 80% chance of dying. So ARDS, really just part of the dying process. Let's pull up our PowerPoint and see what this has to say. Let's see. I'm trying to fiddle with my Zoom, because I'm recording, so. I don't know why I can't ever get these Zoom windows to do what I want them to. There, that works. So this is at the very end of your PowerPoint. Adult, kind of the preferred terminology now is acute respiratory distress syndrome. Diffuse alveolar injury. So the little tiny air sacs in your lungs are injured, and running right along the outside of the air sac is your pulmonary capillaries, and those are also damaged. And so you kind of have almost like a fracture or a broken alveoli. And as you can imagine, all kinds of horrible things happen. The most important horrible thing that happens is you don't get air or oxygen exchange. You don't get oxygen exchange. And so these patients present with severe hypoxemia. And that just means their blood level of oxygen has dropped really low. early on in the pandemic, though, we realized that we could let people get really low oxygen levels, and they would actually do okay. They would do okay a lot of times. And so in New York City, this is where most of this was happening. The early research is they found out that we could just let people sit at a much lower O2 sat than we used to. Just in this one thing with the COVID type ARDS. It is seen in critically ill patients. So if you go visit any ICU in town, pretty much every single patient in that ICU will have this diagnosis. They'll have tons of other diagnoses as well, but for the most part, you land in the ICU because you have ARDS. ARDS means an oxygenation problem, and we're going to have to get on top of that. If that means, it might mean a ventilator, it might mean ECMO. Again, this mentions trauma. Trauma patients are very high risk for ARDS. Sepsis, though, I would say is the leading cause. Drug overdose patients, massive transfusions. That's talking about a blood transfusion. And why do you suppose that is? The reason that a massive transfusion causes lung problems, so let's imagine a scenario where you're suddenly bleeding to death. You're bleeding to death, and a simple fix is to stop the bleeding and then give you a bunch of blood. We give you blood products. When we are infusing blood products, what we are actually infusing is another person's organ system. I think of red blood cells as an organ transplant. And in fact, if we go back to our multi-organ dysfunction syndrome, one of the organ systems that can get completely out of whack and take a hit is your blood. And in that case, we call it DIC. It's its own fancy word. It means your blood as an organ system has taken a hit. Disseminated intravascular coagulation. But if somebody donates blood, and I hope some of you guys do, I think it's a great thing to do, to donate blood. The blood bank here in Lincoln is just right next door. One of the blood banks right next door to the college here, and they come and do blood drives. If you donate blood, they then take that blood and they sort of spin it down so that what we give in the hospital is just packed red blood cells, it's called. The doctor orders packed red blood cells. But in that whole blood that you donate, there's also white blood cells. White blood cells. When you donate blood, you're donating your red blood cells, but you're also donating your white blood cells. When you give blood, your white blood cells aren't angry. They're not pissed off at the world yet. But once they're placed in this little plastic bag, they become very angry. And white blood cells that are angry are the cause of ARDS. And so if we transfuse somebody with maybe 10 units of packed red blood cells, they're getting some white blood cells as well. And those white blood cells are angry. And they tend to just accumulate right there in the lungs, in the alveoli, and start eating stuff. They start eating lung tissue, basically. So massive transfusion There's a name for that. It's called TRALI, which is transfusion-related acute lung injury. But massive transfusions can cause ARDS. Acute pancreatitis can cause ARDS, and there's two causes of pancreatitis, most common causes. First cause is a bad gallbladder, actually. Has anyone had their gallbladder taken out? A couple people here have. If you've had your gallbladder taken out, they might have said in the report that you had so many gallstones. Not everybody has stones, but if you have stones in your gallbladder, every once in a while a stone will kick loose and travel down your common bile duct, which just so happens to be the same tube that your pancreas dumps digestive enzymes out of. That same tube can get plugged up with a gallstone, and that actually is a leading cause of pancreatitis, a bad gallbladder. The other leading cause of pancreatitis, alcohol. Alcohol. The only cause of chronic pancreatitis is alcohol. But if it's an acute pancreatitis, which means you've never had this problem before, but you wake up one morning, maybe Saturday morning, you wake up and you have this stabbing pain right through the middle of your belly. It's a stabbing pain. It's a deep pain, uncomfortable, visceral pain, we call it, which means you can't really localize it. You know it's somewhere in there, somewhere in your belly, and it's just 10 out of 10 pain. What's happening is with acute pancreatitis, your pancreas is actually digesting itself. Your pancreas secretes digestive enzymes to help digest food, but if it gets plugged up, it then starts digesting itself. And that's called acute pancreatitis, extremely painful. Those digestive enzymes that are digesting your own pancreas actually have this tendency, not in everybody, something like 30% of people. Those digestive enzymes travel to your lungs and start digesting your lungs. That's called ARDS, but it's caused by pancreatitis. Your pancreas digesting itself. Again, though, the book mentions sepsis, definitely the most common risk factor. And it is a major leading cause of death, especially today, in today's world with the pandemic. All those people who died essentially died of this, acute respiratory distress syndrome. The second slide on ARDS says they do have this pulmonary edema that's going on. What's happening there is that alveoli, that little sac, it's kind of fractured, it's broken, and then fluid starts leaking into it. And then we check their ABGs, their arterial blood gases, and their oxygen level is super low. That's called hypoxemia. We put a ton of oxygen on this person, 100% O2 via a non-rebreather. That's the oxygen mask that has the little bag attached to it. We can give high amounts of oxygen. But their ABGs don't get any better. And it's very frustrating and helpless feeling as a nurse when you put oxygen on somebody and their SATs don't go up. These guys will be in the 50-50 club. Means their PO2 is 50 or less, and their CO2 is 50 or higher. So their oxygen is dropping, and they're retaining carbon dioxide. So that's the very last 2 slides of the PowerPoint for chapter 21. Any questions? Anybody on Zoom have any questions about ARDS? You guys have any questions here in the classroom? No? ARDS shows up in a couple of places in the book. They just mention it briefly in this chapter, and then in a later chapter, they talk about it again. So they do talk about it in a couple of places, and I think rightfully so, because we see it all the time, and it's what people tend to die from. Well, let's go back to the very beginning of the PowerPoint and kind of dig through some of these slides. I want to point out a couple slides that are interesting. But they're interesting, but as a nurse, as a bedside healthcare professional, you really don't need to know unless you are a pulmonologist. And one thing that you don't really need to know is the difference between obstructive and restrictive, even though that's the name of this chapter. That's based on what are called pulmonary function tests. And pulmonary function tests, there's a couple slides about those that we'll talk about them. But that's a highly specialized thing that unless you personally have severe asthma, you won't see it as an RN for the most part. As a registered nurse, as an LPN, we don't see a lot of pulmonary function tests. With lung disease, I mentioned this last week, smoking is by far the primary risk factor. Secondhand smoke also plays a role. And there are occupational and environmental exposures as well. And this is a field of research we've really focused on in healthcare because nurses are at a higher risk for lung disease. And one reason we think, I just happen to have this bottle of Husker hand sanitizer on my desk. One reason we think nurses are at a high risk for lung disease is all these darn chemicals. I'm putting some on right now. Boy, that stuff smells terrible. It makes me wonder, it just says alcohol. It doesn't say whether it's ethanol or methanol. A methanol is an alcohol. It does kill germs, but it is also absorbed through your skin and wreaks havoc on your body. So a lot of the cheap hand sanitizers early in the pandemic that people were buying off Amazon.com, as it turned out, actually had methanol in it, which is a highly toxic substance to the human organism. Anyway, one of the reasons we think nurses have a higher rate of lung disease is all those chemicals. We are constantly sanitizing, constantly cleaning. Hospitals have always smelled like strong bleach or different types of cleaning agents. So think about that when you're at work. Think about all the really strong fumes you're smelling, because that's not good for our patients either. And as nurses, we need to be vocal and advocates for our patients. So strong fumes, the other thing that the strong smell of disinfectant tells me when I'm in a hospital on a unit somewhere, it tells me that that unit has crappy airflow. It has bad airflow. And we didn't pay much attention to this until the pandemic. If you have stale air in your building, that coronavirus can just be floating around for days. And we're starting to take a look at that. The engineering teams at all the hospitals, I noticed a big difference at Bryan West just in the last semester that I was there. We were on 4th floor and we kept smelling a wood burning fireplace, which was weird because we've never smelled that before. Well, what was going on is the engineering staff had increased the airflow from the outside, which was great. They're washing out that coronavirus. And you know who first pointed this out, that stale air on your nursing unit increases death, was Florence Nightingale. She pointed this out scientifically with statistics way back in the Crimean War, hundreds of years ago. So Florence Nightingale is kind of considered the mother of modern nursing, but I consider her a hero because she was actually the first female, back when it was not politically correct for a female to be a data scientist. If we went out to Wikipedia right now, they don't list her as a nurse, they list her as the first female data scientist, Florence Nightingale. And one of the things she proved is stagnant air increases death for your patient. So be thinking about that. Secondhand smoke, too, big problem, which isn't here in Nebraska. It's now illegal to smoke indoors in restaurants, but that was not always the case. And so waitresses would have a high amount of exposure to the carcinogens just in the average work day, because everybody 20 years ago was smoking in restaurants. We see those patients now. We're taking care of them now all the time. 70-year-old, 80-year-old, often females. We noticed about 1980, your book talks about this. It used to be that COPD was kind of a male problem. About 1980, it started becoming more and more of a female problem, to where now most of our patients were taking care of our elderly females with end-stage COPD. It kind of flip-flopped as far as what demographic. The bronchodilation and bronchoconstriction is an important concept. The lining of your airways, is your bronchioles especially, are lined with smooth muscles. Smooth muscles allow those to dilate to let more air in, or constrict as needed. Very similar to your blood vessels. Your blood vessels also dilate and constrict as needed. And also, the autonomic nervous system innervates your blood vessels, but also innervates your bronchioles. Specifically, beta 2 adrenergic receptors. Memorize that little line if you can, because you'll see that all the time. The reason you see it all the time is the breathing treatments that we give people, the albuterol nebulizers, that class of medication is a beta-2 adrenergic medication. So you'll see this all the time, and every single day of your job, you will be taking care of patients who are on albuterol, either inhalers or nebulizers. And the way that that's working is it's causing bronchodilation so that they can breathe. Adrenergic is a word that means, I think of adrenaline. If you're an adrenaline junkie, if you've ever jumped out of an airplane with a parachute on, you're an adrenaline junkie. Adrenaline is pumped out of your adrenal glands. And so if you have an adrenaline rush, your bronchioles will dilate. The other name for adrenaline is epinephrine. So epinephrine also causes your bronchioles to dilate, which is why people who are allergic to things like bees or peanuts, if you've ever had an anaphylactic reaction, hopefully you have an EpiPen. And the EpiPen is just epinephrine, also called adrenaline, and it hits on these beta-2 receptors, causes your lungs, bronchioles to dilate. Suddenly you can breathe again. You accidentally eat a peanut. 2 minutes later, you're wheezing. Your bronchioles are all clamped down and constricted. You can't move any air. You're starting to turn blue. You take your EpiPen, you stab it in your leg, and within just a few short seconds, really, that epi starts working, reopens those airways. There are chemicals that cause bronchoconstriction, leukotrienes. The leukotrienes are released by white blood cells. Histamine, also released by white blood cells that we call mast cells. These are all chemicals that your white blood cells use during the inflammatory process. So a lot of our meds work by blocking those chemicals. Benadryl, if you've ever taken Benadryl, it's just blocking that histamine. Compliance is just a word that means how flexible are the lungs. The older that you get, the less compliant your lungs are. And it's also reduced by illness like pneumonia. As far as basic anatomy and physiology go, your lungs are lined with a membrane called the pleural membrane. It lines the chest cavity on the inside of your ribs, and it also lines your lungs themselves. So you basically got two layers that are stuck together. They're stuck together with a lubricant. And that lubricant lubricates those membrane layers. But you do have a potential space between the membranes. Usually there's not a space. Usually they're stuck together pretty good. But if something happens where we poke a hole in your pleural lining, you can generate a space, and that space can cause all kinds of problems. One example of that's on the bottom of this slide, the pleural effusion. If somebody starts leaking fluid into that space between those two membranes, a pleural effusion. The word hypoxia means lack of oxygen or low oxygen in the bloodstream. Hypercapnia, elevated carbon dioxide levels. And so with ARDS, we were talking, the PO2 drops, so the patient has hypoxemia. The CO2 climbs. The patient has hypercapnia. High CO2, low oxygen. Our end-stage lung patients can have chronic high CO2, and we call that chronic hypercapnia. It means their CO2 is always greater than 45. Do memorize this normal range. We talked about that with arterial blood gases. Your normal CO2, 35 to 45. Commit that to memory. I would personally write a flashcard. That's how I memorize things. I'm still not very good at memorizing things. But 35 to 45 is the normal CO2. Elevated CO2 stimulates part of your brain called the medulla, part of your brain stem. The elevated CO2 causes you to breathe faster, breathe deeper. That's the normal response. And that actually is what really triggers our breathing. Chronic high CO2 causes all kinds of problems: headache, drowsiness, intellectual impairment. Something I've been fiddling with for a couple of years now. It's driving my family members crazy. I've been fiddling with indoor, we're going to take a break here in a couple minutes. My alarm's about to go off. I've been fiddling with indoor air quality, and as it turns out, I just got a message on my phone. It says here, my CO2 levels are rising. Let's take a look at that. My phone won't unlock because I have this mask on. I haven't. One thing that I have a bunch of little devices. I don't know if you can see. I don't know if I'll be able to get this to where you can actually see it on Zoom. I have a device called a Yoo-hoo, and right now the CO2 in my house, that poor camera doesn't know what to focus on. The CO2 is 1,799. It's in the red. It's in the red. The Yoo-hoo that I have is situated in our bedroom. And what that's telling me is right now there's very little airflow in our house. And I definitely notice the CO2, the carbon dioxide in any given room skyrockets when family is over. So have you ever had like a holiday gathering, middle of winter, Christmas time? It's common because it's too cold to open the windows. Too cold to open the windows. And suddenly you've got 20 people standing around in your living room. It would be interesting to measure your carbon dioxide level, because every adult in that room is exhaling CO2. And the PowerPoint slide, it just said high CO2 causes a headache, drowsiness, and intellectual impairment. So you might have heard that turkey has tryptophan in it, which makes you want to take a nap after Thanksgiving dinner. According to my anecdotal evidence, this, and keep in mind this is not scientific by any stretch of the imagination, I get sleepy after Thanksgiving dinner because the CO2 levels in our house are sky high because there's so many people in there. And the house is all shut up. We don't have good airflow. The reason I'm interested in air quality is because of the pandemic. Is I would like to test the air quality on the nursing units where we work every day. No good airflow. People get sick. and the CO2 climbs, all kinds of problems. Anyway, it is about break time. Anybody have any questions at all?